Welcome back to Decode Healthcare with Harshal. You're tuning in to part 49 of our 100-part ICD-10-CM Guideline Explainer series. Today is a huge milestone because we're officially breaking into Chapter 10, Diseases of the Respiratory System. Our mission today is laser-focused on section IC10.A. We're going to master the coding laws for COPD, crack the asthma severity tiers, decode acute exacerbations, and tackle the incredibly high-stakes rules around status asthmaticus. So if you've ever had a respiratory claim bounce back, today is the day we fix that for good. Let's jump right in. Here's what we're covering today. We'll start with the Chapter 10 respiratory guidelines, look at COPD exacerbation versus infection, sequence our COPD combination codes, navigate the asthma severity classification matrix, and finally, wrap up with documenting status asthmaticus.
All right, let's kick things off with Section 1, Chapter 10, Respiratory Guidelines.
We begin our clinical translation journey by grounding ourselves entirely in the official guidelines. Listen, this is where the rubber meets the road in medical coding. The crucial point you have to remember is that when it comes to medical coding laws, the official CMS guidelines strictly override any textbook you might have on your desk. While textbooks are fantastic for learning the ropes, the CMS official guidelines serve as the absolute, unquestionable foundation for our coding decisions. When an auditor is scrutinizing your claim, they aren't looking at a study guide, right? They're matching your code selection directly against the actual text of the CMS guidelines. Moving right along to our second section, COPD exacerbation versus infection. Let's see how this builds our understanding of COPD category J44, specifically navigating the really tricky clinical realities of exacerbations versus superimposed infections. Now, the guidelines explicitly define an acute exacerbation as a worsening or a decompensation of a chronic condition. Think about a patient whose daily COPD symptoms suddenly flare up. They're wheezing a lot more than usual, really struggling to catch their breath. That's an exacerbation. But here's the critical part. It is absolutely not equivalent to catching a new infection. While an infection can for sure trigger an exacerbation, they are completely distinct clinical concepts. The CMS guidelines demand that we code them accurately based on what's actually happening in the patient's lungs. Look at how these two clinical realities contrast. If your patient presents with COPD and an acute exacerbation, meaning their baseline chronic symptoms just flared up without any documented chest infection, you're going to assign subcategory J44.1. But if an actual acute lower respiratory infection, like, say, acute bronchitis or pneumonia, develops on top of that COPD, you shift entirely over to subcategory J44.0. Choosing between these two paths literally dictates how the rest of your claim is built. Up next, Section 3, Sequencing COPD Combination Codes. So, to ensure our claims sail right through the system without denial, we absolutely have to master hierarchical priority. Ask yourself, when a clinical workflow shows a COPD patient catching a chest infection, like acute bronchitis, how exactly do we sequence those codes to reflect the true reality of the encounter? Which code gets the VIP treatment and drops into slot number 1? It's a super common scenario, but it trips up a lot of coders and leads to immediate payer pushback if it's done wrong. This brilliantly illustrates the solution. When a patient has COPD and develops an acute lower respiratory infection, J44.0 has to take the lead in slot 1. It acts as your anchor combination code. But you can't just stop there. J44.0 tells the payer there's an infection, sure, but it doesn't tell them what kind. So you have to immediately follow it up with a specific infection code in slot 2, which in this case is J20.9 for acute bronchitis. The golden rule to burn into your memory here is COPD plus infection equals J44.0 leads the claim. Never, ever put the bronchitis or pneumonia code first when the patient has COPD. All right, Section 4, Asthma Severity Classification Matrix. Transitioning over to category J45, we face a pretty rigid matrix that we've got to navigate flawlessly. The guidelines step us through 4 ascending severity tiers for asthma. We start at the bottom with mild intermittent, climb up to mild persistent, then moderate persistent, and go all the way up to severe persistent. If your provider explicitly documents these specific severity levels, you absolutely must use the corresponding codes. If you select an unspecified asthma code, like J45909, when the clinical documentation clearly outlines one of these specific tiers, well, you're just begging for immediate auditor scrutiny. Payers want to see the exact severity level reflected in your data. Now, once you've nailed down the correct tier out of those four, you still need precision. For each of those four tiers, you have to specify which of these three final clinical branches the patient is actually experiencing. Is the asthma uncomplicated? Is it with acute exacerbation? Or is it the absolute most severe form with status asthmaticus? You're basically building a highly specific clinical picture using a single combination code that captures both the severity tier and their current clinical status. Which brings us to Section 5. Documenting status asthmaticus. This is the highest stakes scenario in Category J45, and honestly, our biggest audit trap. Status asthmaticus isn't just a bad asthma attack. It's a severe, intractable asthma attack that is completely refractory, meaning totally unresponsive, to standard bronchodilator treatment. And here's a surprising fact. Miscoding this can improperly shift a hospital's DRG weight by thousands of dollars per claim. That is exactly why payers audit these charts so aggressively. You absolutely cannot assume a patient has status asthmaticus just because they got aggressive ER treatment or were breathing heavily. It is a distinct, life-threatening clinical diagnosis, and the coding laws around it are incredibly strict. You must see explicit provider terminology, just like this note here, proving the asthma was refractory to treatment before you can validate and select a status asthmaticus code. When an auditor is digging through the medical record, they are looking for exactly this kind of language, unresponsive to initial continuous nebulizer therapy, directly linked to the physician's declaration of status asthmaticus. When you have that rock-solid documentation, your code validates perfectly. Without it, choosing a status asthmaticus code is a massive compliance risk. And that is how we conquer Section IC10.A. Be sure to subscribe, hit that like button, and share this explainer with your fellow coders to keep everyone's claims clean and compliant. Join me next time as we hit a massive milestone, the halfway mark of our 100-part series. In Part 50, we'll dive into Section IC10.B to decode acute respiratory failure. How exactly do we sequence an acute on chronic failure, and what happens to our claim when mechanical ventilation enters the picture? I'll leave you to think about that, and I will see you in the next explainer.